We differentiated between various bone and joint infections and identified microorganisms associated with these infections, and given a patient case, we selected effective drug therapy for treatment of bone and joint infections along with total duration of therapy. Now, given the patient case, let's develop a monitoring plan for antimicrobials used in the treatment of bone and joint infections. The 2015 IDSA guidelines for native vertebral osteomyelitis recommend monitoring systemic inflammatory markers, specifically ESR or CRP, after approximately 4 weeks of antimicrobial therapy. If after 4 weeks of treatment with antibiotics, ESR and CRP are unchanged or worse increasing, then there should be a suspicion for treatment failure. When it comes to imaging, it is not recommended to have in general routine follow-up MRI unless there is a need to assess evolutionary changes of epidural or paraspinal soft tissue in patients with NVO or in patients who have poor clinical response to antimicrobial therapy. Here's a list of IV antibiotics that are used outpatient for the treatment of bone and joint infection. Rifampin is also available as oral, so it is often used orally for the treatment of bone and joint infection. Keep in mind that according to the 2018 IDSA guidelines for OPAT or outpatient parenteral antimicrobial therapy, it is recommended to check CBC and so complete blood count and basic metabolic panel weekly for outpatient monitoring for all of these agents. For some of these agents that are more likely to assault the liver chemistries are also recommended to be monitored weekly. And of course, nafcillin, ceftriaxone, and rifampin are not renally adjusted. Now, on this list, every agent is available as oral formulation with the exception of vancomycin and daptomycin. So vancomycin and daptomycin must be given as IV for the treatment of bone and joint infections. Again, for most of these agents, IDSA recommends a weekly monitoring of CBC and BMP. And for some of them, you also need liver chemistries. And for vancomycin, it is also recommended to check a weekly vancomycin trough. And for daptomycin in particular, it is recommended to check a CK or creatinine phosphokinase weekly. And it is recommended to discontinue daptomycin in symptomatic patients with a CK of more than 1,000, or if they're asymptomatic but their CK is more than 2,000. And 2,000 would basically be equivalent of 10 times upper limit of normal, and 1,000 would be equivalent to 5 times upper limit of normal. And this is because this increase of CPK due to daptomycin can increase patients' risk of rhabdomyolysis. So these symptoms would basically be muscle ache and other symptoms of rhabdomyolysis. Now, in particular, moxifloxacin and doxycycline as well as linezolid do not need to be renally adjusted. Now, what exactly is outpatient antimicrobial therapy or OPAT? According to IDSA, OPAT is defined as the administration of parenteral antimicrobial therapy in at least 2 doses on different days without intervening hospitalization. And the use of OPAT can significantly reduce hospital stays when oral therapy is not an option. Now, parenteral antimicrobial therapy is traditionally offered in an inpatient setting. However, outpatient delivery of antimicrobial therapy has increasingly been used to facilitate early discharge from the hospital. The goal of OPAT programs is to provide the required infrastructure for optimal patient selection, monitoring, and treatment, and to enable patients to complete IV therapy safely and effectively in one of the outpatient settings. Many studies have confirmed the safety of OPAT with appropriate antimicrobial selection and monitoring while reducing the risk of healthcare-associated infections. Patients with recent histories of injectable drug use are generally not considered candidates for OPAT because they may use vascular access devices to inject drugs. For these patients, we may consider long-acting antibiotics such as dalbavancin, which can be injected once weekly, eliminating the need for vascular access devices in these patients. IDSA guidelines make no recommendation whether people who inject drugs may be treated with OPAT at home. Decisions should be made on a case-by-case basis. For patients who qualify for OPAT, OPAT can significantly increase quality of life, allowing them to participate in most normal daily activities while completing treatment. Patient education is crucial. Because extended treatment duration is common, patients need to understand the importance of adherence to the selected treatment and monitoring plan, as well as the associated toxicities they should report to the healthcare team. This concludes this presentation.